Welcome, everybody, to the 8th session of Growing Stronger's LP Doc Talk. Today we have with us Dr. Shawn C. Standard, who is the head of pediatric orthopedics at the International Center for Limb Lengthening. Originally from Atlanta, Georgia, Dr. Standard came to the ICLL in 2003 from the Distinguished Nemours Clinic in Jacksonville, Florida, where he started a combined general pediatric, orthopedic, and limb deformity clinic. An internationally known surgeon, Dr. Standard has expertise in the treatment of limb deformities with a special interest in skeletal dysplasia, or dwarfism. Dr. Standard also takes his expertise overseas, serving as a volunteer orthopedic surgeon in countries like Grenada and the Dominican Republic. So welcome to the session, Dr. Standard.
Great, thank you very much for having me.
You're welcome. And we also have with us today special guest, Chandler Crews. Chandler is a 22-year-old nursing student at the University of Arkansas at Little Rock. Chandler was born with the most common form of dwarfism, achondroplasia. In 2010, when she was almost 17, Chandler went to the International Center for Limb Lengthening. Since 2010, she's had a total of 3 limb lengthening procedures, lengthening her legs twice and arms once. She's been documenting her journey on her Facebook page called Chandler Crews, formerly Chandler in Baltimore, and has begun a Facebook group with a friend called LEAD, Limb Extension Awareness for Dwarfism, a positive forward-thinking group which invites all to openly discuss the concept of limb lengthening for dwarfism. Chandler also serves as the district director of Little People of America for Arkansas, Kansas, Missouri, and Oklahoma, as well as working for Growing Stronger. So Chandler is here to offer the patient perspective of any of your questions. So welcome, Chandler. Thanks for being with us.
Thank you for having me.
And at that, Dr. Standard, I'm going to hand it on over to you.
Okay, great. I have a list of questions that I'd be happy to answer and hopefully expound on a little bit. And Chandler, if you feel like there's something to jump in and add, I would be greatly appreciative. Having your perspective as well is very important. The first question reads, my daughter is 10 years old. Is it okay to begin lengthening the arms first before lengthening her legs? And along with that question is, can a child of the age of 10 handle such a life-changing and heavy operation? What can go wrong, complications during surgery, and how often does it happen? What are the things we need to think of when she is home after surgery for her well-being and state of mind? Is it okay that she's having doubt? She's talked about the surgery and says she wants to do it, but isn't 100% sure. Can someone really be 100% sure? So that covers a lot, and we'll start one at a time. But these are great questions. And so, at the age of 10, can you begin lengthening arms? And you can. The protocol typically for, and we'll kind of go through a prototypical case of achondroplasia or hypochondroplasia. There's over 200 types of bone dysplasia, and each of them have their own particular issues when dealing with orthopedic treatment, and some have, and many have, other issues with other organ systems or other issues that need to be certainly addressed to make sure that surgery or any type of elective surgery is safe. As far as hypochondroplasia and achondroplasia, lengthening can begin between the ages of even as young as 8 years of age. Typically, if someone is looking to start early, between 8 to 10 years is a good starting time. Typically, the protocol begins with bilateral lower extremity lengthening both the femurs and the tibias, while at the same time correcting any deformities that are present, meaning any bowing, any twisting type deformities, any other gait problems or joint problems you'd like to address either at the same time of lengthening or even prior to lengthening. The second stage is a second limb lengthening, usually around the age of skeletal maturity, which means as the long bones finish growing, typically in the age 14 for girls, 16 for boys, the second lengthening is performed, and then the final lengthening is the arms. That protocol was established by several doctors. We all do it a little differently. And at the Rubin Institute for Advanced Orthopedics, that's kind of the prototypical schedule. However, everyone can modify and change that depending on their needs. First of all, lengthening is not for everyone. And if lengthening is for you, then it might be a single lower, leg lengthening. It might be a lower extremity lengthening one time. It might be a one-time lower extremity lengthening and a arm lengthening. It might be the full protocol. I've had some patients who've done 3 lower extremity lengthenings and 2 upper extremity lengthenings to correct deformities and add length, all depending on proportionality and function. If I meet a young person, and this is a young girl at age 10, and she's having significant problems because of her arm length with day-to-day care needs, bathroom self-care, then certainly you can do arm lengthening. There is some concern by doing extensive lengthening, because these lengthenings are extensive, that could you perhaps inhibit normal growth of such a young child. It is theoretical, but I have not myself seen that. We do have literature, but it's more in line with congenital limb deficiency lengthenings and not with bone dysplasia lengthenings. So from a doctor's point of view, extensive lengthening in a younger child with open growth plates theoretically could slow the growth plates down because of pressure, but I've never seen that. So I myself am happy to perform a arm lengthening at the age of 10, and you can gain anywhere from 2 inches to 4 inches of arm length from the upper arms, the humerus. You do want to take into consideration, is leg lengthening being considered? If it's not, and it's just arm lengthening, then you want to provide a functional length, but you do not want to create significant disproportionality, because the families will not be happy. And hey, Chandler.
Yes.
I'm right in the middle of that, and I'm sorry, I know this is being recorded. My little one's called. I just want to close my doors real quick.
Oh, you're fine.
I think mommy is taking care of little Peanut, but okay, sorry. So so you definitely can do your arms first. Can a child of 10 handle such a life-changing heavy operation? They can. That was a concern early on, and we would perform maybe only bilateral femoral or upper leg operations, and then followed by bilateral lower leg operations. And in concern that a younger child, would not be able to tolerate both femurs, both lower legs, tibias, and fibulas being operated at the same time. And what we come to find out is that they do very well. It is a significant investment in time, and usually the patients are not local. Most of my patients come from out of town, so it's a huge investment of work and time and effort on the family's part, along with the patient, and Chandler can attest to that.
Mm-hmm.
And it's definitely a journey, and I think that's when you really have to, I think as a family, explore the options, talk to an experienced surgeon who treats this often, and also to.
I would also say, talk to other patients who have gone through it and their families. Especially, I think I get a lot of questions from mothers asking questions about, how did you go through it and something and all that. And I think moms should also, message other moms of, if their child's gone through it, so they can sort of get, that sort of mom and mom, I don't know what the word I'm looking for is, But, when I'm answering to a mother, I feel like that's different than if my mom was to sort of answer to a mother who's considering the surgeries for their children.
Yeah, I think that's great. I think the different perspectives are extremely important when trying to prepare yourself. And you can never 100% prepare yourself, at least, and Chandler can answer that also. But I always highly recommend families to first meet a doctor and meet an institution and understand the undertaking that they're considering and all the time and effort implications. At the same time, like Chandler said, I have performed thousands of operations, but I've never had to care for a child who's undergoing bilateral lower limb lengthening myself. So that's where the family knowledge comes in and the wealth of parental knowledge that we have, especially in my practice and the wonderful kind of community that's developed, that people are very willing to share each other's experience. I call that this parental knowledge base. How do you get to an airport with external fixation devices on? What does the magnet look like? How to get the magnet through security? How do you travel in a car? Yeah. What kind of clothes do you wear? And all of these things. How long does it really take? All these things are extremely important information. And I think the more you know, and the expectations, especially of a younger child, you can really manage better. And there's certain signs, if a child 8, 9, 10 is can't wait to wake up with arms and legs like mom or like their brother, if they're and that's an unrealistic expectation. One, we're all different and we all have our individual pluses and minuses and challenges and good things and bad things. And that maturity is very important for this type of undertaking. I operate on children as young as 1 year of age for limb lengthening and deformity reconstruction, all the way up to adulthood. And the different procedures require different levels of maturity and understanding. And this is definitely one where that's extremely important. Meaning that would you undertake a bilateral limb lengthening at the age of 5 or 6? And you shouldn't, at least not in my practice. They're not prepared for that. You can do deformity correction, but not extensive lengthening. So I think that answers can a child of age 10? They can. And I've had multiple examples, many patients, and just Chandler's one who can, even though Chandler is a little older, but still, it's amazing what the patients can show you that they can do. But and it is a journey, and everyone takes a little bit different road in the journey, meaning their goals, but the goals aren't the penultimate of achievement. If you come in looking to increase the leg lengths by 4 inches, and at the 3-inch mark, there's some signs that say that the body has had enough, then that's when you need to stop and regroup and understand that that's what your body can take. The fourth part of this one question is what are the things we need to think of when she is home after surgery? I think it also depends on if there's external fixation devices or internal devices, and they're a little different. But when you return home, first the returning home is the second stage. The first stage is the lengthening itself. Every limb lengthening surgery is broken up into, I would say, 3 or 4 parts. First, the surgery and the inpatient care. Second is the time that you're actually lengthening the leg or the arm, the bone segment, if you will. And then the healing portion of that, once you finish the lengthening, you stop the lengthening and the bone has to heal. And then the fourth step would be final recovery and rehabilitation. And I think any extensive lengthening, most patients will tell you to get to that stage 4, probably about a year. It might be even a little bit longer. So the surgeries and the inpatient stay are usually somewhere between anywhere from 3 to 5 days. The lengthening process, what we call the distraction or lengthening phase, can last anywhere from 2 to 4 months. And now this is the hard part, is in that 2 to 4 months, especially in your first lengthening, you're here in my practice, you're here on campus, special housing that we can provide. We have a little house that has kind of a low fee stay, and we also have a Ronald McDonald House, which is a blessing. And patients stay here for anywhere 2 to 3, even 4 months, undergoing daily physical therapy and lengthening and visits in the office every 2 weeks. And that type of protocol is very arduous, but it's very successful because this is not a small surgery. It's a big undertaking, and I think that kind of falls into the next thing is I think it was part 3 I missed, is what can go wrong, what are the complications, and any surgery brings multiple complications, and I usually tend to kind of group complications depending on the particular surgery that you're performing. In limb lengthening in general, there are always risks of the joints above and below the limb being lengthened, either dislocation, stiffness, or contractures. The bone itself might not heal. There's blood vessels that can be either injured at the time of surgery, it can be injured during the lengthening process, nerves that can be injured or irritated during the lengthening process, a host of orthopedically centered issues. The blessing is that they're extremely rare, and to date I've had less than 1%, probably less than 0.5% incidence of issues of nerve injury. As far as bone healing, we've had 100% bone healing. Sometimes it takes, if someone has a difficulty in healing their bone, it might require some other surgeries to correct that. But at the end of the day, I've achieved all bone healing. Limb alignment, you want to make sure that you maintain the straightness of the leg or the arm in both rotation and kind of not inducing any secondary deformities. And so there are a host of things that can happen. They're extremely rare. I think some of the non-orthopedic issues, we look at basically the overall health of the patient, heart, lungs. You're undergoing anesthesia, which is very safe in this modern day, but there's still risks. One issue with, especially with the bone dysplasias, are the central nervous system and the amount of space available for the spinal cord and nerve roots. And there are certain situations that put patients at a much higher risk, if, especially with a thoracolumbar kyphosis or a spinal deformity that has been corrected, places you at a much higher risk of really any type of, having a secondary stenosis, which would then place you in a different protocol to achieve a safe lengthening result. It also places you in a protocol for a different preoperative assessment to ensure that there's no problems that that would sneak up on you. And I'm sorry if there's background noise. That's, believe it or not, that's my dog snoring. So I apologize. But I think, did that cover everything, Chandler, for the first one?
Yeah, it did.
And then, I think if a patient's not having doubts, it says, is it okay that she's having doubts? Then I'd be kind of worried if you're not having doubts, because I think that's very normal when approaching such a large surgery. I don't know, Chandler, did you have doubts?
Definitely. I think, like like Dr. Standard just said, I mean, it's definitely very emotional, and I feel like there's definitely your good days, but that doesn't mean it's going to be all good days. Like, there are going to be your bad days, and there might be, like, I mean, I did have days where I just told myself, I was like, I can't believe I did this. Like, why did I do it? But then, like, 5 minutes later, I'm like, I'm going to get through this, and it's going to be awesome. And, like, I honestly tell everybody, it's just, for me, it was totally worth it. Like I am like so happy with how everything turned out, and it wasn't easy though. I've had 2 leg lengthening procedures, and they definitely like both were not completely easy, and there were bad days, and there were times where I was like, maybe we need to just stop, like not do the full lengthening and just stop halfway or something. But I mean, I think it just kind of depends on the person, and I think, each person's different, but I think everybody will sort of get like what they want to happen.
And yeah, I agree. And goals can change as the time goes on, but I do think it's definitely something that you can't jump into very quickly without doing your due diligence, getting your family support, setting up your life, and especially if someone asks me what's the goal of limb lengthening and bone dysplasia, and I first, because I've been asked multiple times, is this a cosmetic surgery? And and are you saying every patient with bone dysplasia should go through this? And I think first it's a very personal decision, and I do not advocate that every patient with bone dysplasia, whether it's with or without deformities or with or without short stature, trunk, or lower limb statue issues, should undergo lengthening. I think it's a very personal thing, and I think it shouldn't be dictated by doctors, and it also shouldn't be mandated or pontificated by doctors that this has to happen. But I think if you ask me in my heart, what do I change the most? I think probably 3 things, and one, there is a functional height in society as far as just basic utilities and basic size of things, chairs, desks, cars. And usually if you are between the height of 4'10" and 5 foot, or even 5'2", in that range, then all those things are accessible. I think the second thing is the humeral lengthening, I believe is huge for functional distance and self-care and self-needs, especially as time goes on. And we all get stiffer as I've gotten older. You don't touch your toes as well and reach places that you need to reach. And so the humeral lengthening is a pretty amazing and functional improvement. I consider the lengthening and the limb alignment extremely important. The limb alignment even more so to prevent early onset degenerative disease or arthritis. The lengthening to really improve functional abilities. And so it's not a cosmetic surgery. It's a very functional surgery that has positive cosmetic side effects. Some surgeries have negative cosmetic side effects, but this is one that has a positive cosmetic side effect. It's not the main issue, and it's not the main goal, but it is there. And I think some of the things that my patients have told me have really kind of made a difference, over the years after a lengthening or an arm lengthening, what they could accomplish when they couldn't before. And those kind of things, for that person, it was the right choice. So if we move on, and I'm sorry, I don't want to talk too long. We'll go to question number 2. For straightening in the legs with achondroplasia, why is the method used sometimes what's called 8 plates or guided growth, sometimes osteotomy with permanent plates, and sometimes the big rings that go around the outside of the legs, the external fixation devices, well, I like that. It's like some people call them halos, some cages. Is one of these methods better or safer than the other? So those are 3 methods of straightening a leg. One is guiding the growth of the leg. Second is acutely or all of a sudden making the leg straight by cutting the bone and fixing it with some type of device. It can be internal rods or plates. It can be external, and your leg's straight automatically as you leave the OR. Or you can put on devices that gradually straighten your legs, and these are usually external fixation devices. We don't have reproducible, predictable, or gradual internal devices at this point to straighten legs. It depends on the age. Guided growth is just that. You have to be growing. In the years past, the types of devices that very small implants we put around the growth plate were not thought to be viable in patients whose growth plates have an underlying growth difference or a dysplasia. Dr. Peter Stevens from Utah had developed the original, what we call the 8 plate. There's multiple different forms and shapes of this type of device now in the market that gradually improve the alignment with growth. And he has shown that even severe deformities can possibly be addressed and corrected in this way. And so if a patient is not symptomatic with their deformity, they're growing, and they do not wish to increase the length of that bone segment with deformity correction, then an 8 plate is a very viable option, very easy, meaning day surgery, and there's no drawbacks to it. The disadvantages, I think, of the guided growth type surgery is that it's not guaranteed that the growth might not correct the deformity, could improve it but not correct it completely. And you still might have to perform other surgeries. You're not going to gain length from guided growth as far as distraction, histogenesis, or osteogenesis, making bone. But it's definitely, if you are a 5, 6, even 7-year-old patient with significant bow legs, knock knees, things of that nature, and if it's not symptomatic, then there's very little downside of trying to straighten the legs with these devices. I think the acute osteotomy with plating or rotting or external fixation is really kind of relegated to very severe deformities that are very symptomatic, and you don't have the luxury of time because the 8 plates happen over months, 8 months, 12 months, 18 months of growth. So if you have a severe deformity and you're symptomatic, then you would want the leg straight faster. The gradual correction is for extreme deformities that even making the leg straight in the operating room would create too much of a risk for the soft tissues around the bone, the nerves, the blood vessels. Then the gradual distraction correction with an external fixation is the best. And you can also add length. And so I think it depends on the patient's goals and expectations. They can all be very safe. It just depends on the age, the severity of the deformity, and what are the goals. Question number 3 is, can leg lengthening be done after spinal fusion? It can be. If you've had a spinal fusion or a spinal surgery, you do fall into a different category. When you look at, and if you look at the most severe complications in any surgery, but in specifically limb lengthening surgery and achondroplasia, obviously any kind of, what's the most severe? Well, obviously death. Second would be, any type of spinal cord injury, or any other kind of major body complication or organ system complication. In achondroplasia, it's typically you're looking at spinal cord possible injury. The only spinal cord injuries that I have experienced in my practice are patients after spinal surgery with specific deformities. And so if you fall into that category, and I have to say it's been extremely rare, but if you fall into a category that you've had a spinal fusion, one, with achondroplasia, you should definitely during your spinal fusion have undergone a spinal decompression. If that hasn't been done, then you definitely need further workup preoperatively, meaning an exam, something called a CT myelogram or an MRI to make sure that the space available for the cord, there's not a critical pinching of the cord already present but asymptomatic, that could become evidence after any type of major surgery and positioning, different type of anesthetics, whether it's an epidural or what we call central axis anesthesia, could create too much pressure on the cord. Have I performed limb lengthening after spinal surgery? I have. Multiple patients have had, and it's very typical to have lumbar decompressions and instrumentation. And those patients are very safe. If all checks out in the preoperative kind of assessment, then it is safe. If you've had spinal surgery and you haven't had a decompression, if you've had especially what we call sagittal plane correction, where if you had a kyphosis corrected, then you fall into a much higher risk category, and you really need a very detailed neurosurgical evaluation and assessment prior to any limb lengthening procedure. Can arms and legs be lengthened at the same time? In my practice, no. You need one or the other while one set's being lengthened. So if you're having your arms lengthened, then you need good legs to walk around on. If you're having legs lengthened, because during the leg lengthening, your mobility is significantly limited, whether it is bed to chair mobility or household ambulation or eventually full ambulation. If you're using, you need your arms to help you maneuver. So those are definitely different, sections of surgeries.
I would say I got my arms toned during both of my leg lengthenings, because you use a lot of your arm muscles to move around and get,
Chandler, your
one place
biceps and triceps, right? Just getting around.
Yes.
So before I go on, let's see the osteotomies. Let's see spinal fusion, arms. Anything you want to interject, Chandler?
I was thinking about back to where you were mentioning about when people ask you, like, is it considered cosmetic, and like, what are the, I guess, benefits and stuff from it. I always say it does definitely have cosmetic benefits, but one of the great things I feel like that I got from having these surgeries is being able to have face-to-face communications with people now. Like, I could obviously never do that before. I was thinking about, like, the first time, I'll just say, like, the first time I met you, I obviously was, like, below your weight, and now I think I'm, like, right under your shoulder. And so, like, that's completely different when you're, I think, especially for adults, when you're, like, in the adult world and you're wanting to have a conversation with another adult, it's, like, hard when, or for me, awkward. It was awkward to, like, it's better now.
Yeah, and I think that's one of the statements that you mentioned, one that really stick with me. I had one little a young boy say that now he was 9 years old and he can actually use the bathroom without an assisted step stool. And
Yeah.
Chandler, you're saying I can actually see face to face. I'm not under people's waists. Talking, and I think those are huge benefits. I have patients say they can actually reach across and touch the faucet. They can self-care is much better. Doing their hair is easier, with arm length and all kind of things. It's that's what keeps you going, are those changes that as people without achondroplasia, I think, have no business in judging, or as I call it, pontificating on what should and should not be done. I don't think, I think as doctors, we need to assess what can be done safely, how to do it safely, and how to prepare the patients to get through the journey, the patients and the family. All right, so it says, this is question number 5, how long do the external frames have to stay on? How exactly do the frames work? Can the internal lengthening rods be used during the first lengthening? And so, how long do the frames or any type of device stay on depending on the amount of lengthening? So the external fixation device It's usually if something's internally implanted, you're not too worried about how long it's got to be there because it's inside and it can stay there as long as it needs to or even longer. The external fixation device, once you put one of these things on, the clock starts ticking, when do I get this off? And the rule of thumb is that for every centimeter gained, it requires a month of turning and a month of healing. And so if you do a 6 centimeter lengthening, that's 6 months of external fixation wear. The typical protocol for my first lengthening is 6 centimeters in the femur and 4 centimeters in the tibia and fibula, which equals 10 centimeters or 4 inches. A lengthening, that's usually in the age of 8 to 12. The children who are 13 to 15, 16, more in the skeletally mature stage, the goal is between 8 centimeters in the femurs, anywhere from 6 to 8 centimeters, and 5 to 7 centimeters in the tibias. And so for a 8 centimeter lengthening in the femur, it's an 8-month process. The amount of time that you're actually manipulating the devices, when that's the hard part. The distraction phase is the riskiest part. You're lengthening the bone, you're having to undergo aggressive physical therapy and multiple office visits. That's usually, in my mind, it's every 2 weeks you gain a centimeter. And that's at a certain rate of distraction, but that's what it kind of averages out to. So for 8 centimeters, that's 16 weeks. And then the rest of, that's 4 months, the rest of that 8 months is healing. Another 4 months of healing. The frames work, external fixation devices are devices that are outside your body that are connected to your skeletal system by tensioned wires or things we call half pins, or these, they look like large screws that penetrate the skin and go into the bone. And you put them on in very safe zones away from, we call it quote unquote the good stuff, you know, the blood vessels, the nerves, try to stay out of impinging muscles and joints and such. And it's an extremely strong device. It holds on to the bone segments. In between the two fixation points, which could be rings or on a rail, 2 different pin clamps that hold pins on each side of the bone cut. You make a bone cut with different methods, oscillating saw. Usually what I do is drill multiple tiny little holes, and I use an osteotomy, which is a fancy term for a bone chisel, and you crack the bone. And essentially bone lengthening is you're fooling Mother Nature. When any of us break a bone, our bones bleed around the break and they start to form new bone. And with limb lengthening, you break the bone, you allow that early bone healing to start 5 to 7 up to 10 days. And then you start turning your device, which means you're manipulating a turning screw or a turning device on the frame that gradually pulls the 2 segments of the device away from each other at very small increments. It could be 0.25 millimeters every time you turn. And those small increments gradually pull the bone apart, so you're basically staying 1 step ahead of the bone healing that naturally occurs. And it's very important that you manage that rate or how quick you pull apart to make sure that the bones do heal and do grow, and that you don't do it too quickly where you kind of quote unquote outrun the bone and you don't form bone, or if you do it too slowly, the bone heals and then you're pulling against a solid bone. So that's how the frames or even the internal lengthening devices work. They all work the same way. The biology is a little different depending on internal, external, kind of from a doctor histologic point of view. The internal rods can be used during the first lengthening if you're older. The rate limiting step for the lengthening rods is the shape of the bone and the maturity of the bone. So the rods can only get to a certain small diameter and small length. So if your femur is too short for the smallest type internal rod, then it can't fit. If your femur or tibia are too narrow, the smallest diameter is an 8.5 millimeter diameter. The shortest distance, realistic distance, is about 19 centimeters in length. We do have shorter rods for smaller length gains, but when you're really undergoing a limb lengthening, you want to at least achieve somewhere between 4 to 5 centimeters per segment, if not more. If the tibia is limited in the fact that the way you put the internal device in, it has to start from the upper part of the tibia and go straight into the bone, and that's where the growth plate lives. And so if you're still growing, you can't use an internal device in the tibia. You can sneak around the growth plates in the femur, and so that's why ephemeral internal lengthening can be done. I've done it as young as age 8, even 7 in some other conditions. But the tibial lengthening is usually reserved internally for girls at the age of 14 and boys 15 to 16. There are unusual circumstances, but that's the norm. So I think that finished that one. Number 6, not all doctors who perform limb lengthening will do so with those with pseudoachondroplasia. What are your thoughts, and why is it more risky with pseudoachondroplasia? And have you have any experience with this? And I do. I have multiple patients with pseudoachondroplasia. The problem is semantic. The name pseudoachondroplasia makes you think that it's related to achondroplasia, and it's not. They're completely two different bone dysplasias. Pseudoachondroplasia is more related to what's called metaphyseal epiphyseal or spinal epiphyseal dysplasia, whereas achondroplasia and hypochondroplasia are a separate entity. The problem with pseudoachondroplasia is that this type of bone dysplasia not only affects the growth of the bones, but also affects the development of the joints. And the fact that the joint development can be very abnormal, and it can also have severe instability. And so lengthening can complicate both of those issues, where achondroplasia does not have that issue. Have I successfully lengthened patients with pseudoachondroplasia? I have, and I've done the same type of lengthening I've done with achondroplasias. But that is a secondary issue that you have to keep in mind, and the goals might be different because of the joint instability. The most important thing for any person is to have correct limb alignment to avoid long-term degeneration, arthritis, and pain, or wearing out of your joints. Those who have abnormal joint development to begin with really need very straight and quote-unquote well-aligned legs. And that's important for pseudoachondroplasia. If you can gain length safely at the same time, that's great. If you can gain length safely without compromising those joints, then I think that's okay too. But you do have to understand it's a whole different category and risk stratification, where you might gain only 2 inches from a limb lengthening, where an achondroplasia a patient might gain 6 inches. And so that's my thoughts. But it can be done, but you do have to keep that under consideration. Question number 7 is, how much length can my child gain with one surgery? And it really depends on age, but typically it's between 4 to 6 inches. And that's in 2 separate segments, meaning femur and tibia. If you're lengthening only in one segment, then you can gain 3 inches in one segment in the legs. And in the arms, you do gain 4 inches in the humeruses, and that's able to be done. But that's under my protocol, which is common for both myself, and I should say my partner, Dr. John 𝘾𝙊𝙉𝙑𝙍𝙍𝙍, who is actually the director of the Rubin Institute, my boss. That's our protocol. And sometimes you do want to, how much you can get. It's, you do want to push as much as you can, but you never compromise the function of the limb, the joint safety, blood vessels, nerves, for length, obviously. But I'm sure Chandler can tell you that, when you're going through this and you put so much effort, you do start, you get you push towards every millimeter. Every millimeter counts when you're in the heat of the battle, but you do have to kind of step back sometimes and realize, that's not the ultimate goal when there's, when you can have complications. And as Chandler said, her lengthenings have not been easy. And so she can, kind of elaborate on those if she wants, but she could give you a better perspective on that.
Yeah, I think, like, I remember thinking, like, my first time when I had the surgeries, and someone said, it might have even been you, like, when you lengthen about a millimeter a day or something, and that's a day of, an extra day that you've got to grow the bone. And I remember thinking, I was like, well, crap, that's going to be like forever. But because I lengthened to 6 inches with my first surgery, but I think I gained 8 because just 2 of those inches were from the correcting of my bowing in the legs. And so I remember thinking, I was like, you think it's going to take so long for it to, to get the length that you want. But I mean, honestly, it goes by so fast, I think.
Yeah, and I think and it is funny as patients come to see me, and I receive consults and emails. This mistake, a lot of times, it's patients start shopping and they start looking at, the doctor. So kind of, it's not really about the doctor. Well, it is, but it isn't. It's there are certain doctors there are several of us who are very experienced in this, but it's more about the institution, meaning that you do want to have the doctor with the skill and the experience, but more importantly, you want the institution and the team that has the skill and experience. I do mission work. I go to hospitals that I cannot perform the surgery in those hospitals. I can physically perform the surgery, but it will not go well and it will not be successful because I don't have the institutional backing, the team, and actually in my practice now, the patient, family, community, which makes all the difference. And that's the one thing when patients from wherever in the world, you need to find an institution that have all those components, not just a doctor, but the housing, the physical therapy, which is the utmost important. That's
what I was just going to say. I think the physical therapist and the physical therapy is what sold me, I would say, because I know it's very, very important. Like, physical therapy is like the number one thing with this, and especially when a patient goes home. I remember with my first surgery, it was hard to find a physical therapist here where I live because everybody here, they're not familiar with a lot of the lengthenings and stuff. And they were like, we'll just address her when she gets here. And we're like, no, my physical therapist was like, I'm going to tell you, like, this is what she's going to need it, how it needs to be done. Like, I know there's like a lot of special techniques that go along with the physical therapy with the limb lengthening, and it's very important to have the right people.
It is it seems like the doctors get all the accolades, but really nothing that I do ever in the operating room comes to fruition or success without my physical therapist. And that's really the physical. I think the 2 most important ingredients in successful limb lengthening, especially in achondroplasia, is the physical therapy and the planning by the family, meaning the effort and determination and perseverance. Because if you don't have those 2 things, you won't win. You have to have a good surgery, and that's the doctors that I know that do this all the time. This is what we do, and that's a very constant. But it's where failure occurs is if you lose your determination or perseverance and you decide you just have to, we're just going to go home and see what happens then, or we're going to accept this lesser quality physical therapy. It doesn't work. And that's really where, before you jump into this endeavor, you really have to have that sorted out. You have to have the time and the ability to put the effort in and get to the right institution and stay there during this this process. And it can be amazing. It can be very, very successful. But those are the kind of things, and that's why it's not for everybody. Question number 8, does insurance cover the surgery? Yes. With the diagnosis of a bone dysplasia, I have never, knock on wood, been denied insurance authorization in the United States. I've had a couple of times where I had to fight with insurance companies and with peer-to-peer medical directors who like to decide what's best for a patient, but I don't think that's our business. Our business is to give you recommendations of what can be done and the benefits and the risks, and I think the decision should be the parents or the patient, depending on the age. So sometimes it does take a little effort. The healthcare laws are changing, and so sometimes if you are looking into this type of surgery, you do want to make sure that your healthcare insurance does afford this, not only the surgery, but once again, this is where physical therapy becomes very important. Some insurance plans give you very limited physical therapy, and that's where the rate limiting step can come. So doing your due diligence, getting ready for a surgery, you really have to pour over your benefits, make sure that you have adequate physical therapy or the ability to even appeal and get more physical therapy as you go into this surgery and get that pre-authorized. If it's not, some patients will decide what year they're going to have their surgery and they switch their plans to a higher rate coverage for that year and then help cover that. But that's, we have financial coordinators that help with that in our institution, and most institutions would be able to help you with that. Number 9, how is the pain managed? What medicine is prescribed to help with the pain? So the pain, there's acute pain management around the type of surgery, and I'm a big believer in pain management. I have changed my ways because as you live and learn or you have issues, I used to use lots of epidurals and central axis medications, which was very safe. But once again, when we talk about spinal surgeries and spinal deformities, it can, in a very rare instance, cause major complications. So at this point, I use regional anesthesia, which is nerve blocks augmented with what's called patient-controlled analgesia, where you have intravenous pain medicine that is dosed on patient need, and then oral pain medications as you recover from the surgery. You have to understand that surgery continues in limb lengthening, not for hours. It continues for months. So as long as you're lengthening your leg, in my mind, you're undergoing surgery. And that requires pain medicine of some sort. Is it a narcotic base? Is it Tylenol or acetaminophen base? Is there muscle relaxant type medicines that needed? All of those things play a part, and I have a whole team that manages that through the process. So I believe in children and patients who are medicated and having good therapy versus patients who are uncomfortable and not having good therapy. And the medicine is very safe if it's managed appropriately.
I would add, oh, sorry.
I would say, what would you think?
I was just going to say, I would add to that I know everybody, and I'd say it to parents and patients too, that it's definitely always like those first that are very tough, because obviously one, your legs are like swollen and your body is adjusting to these new changes. But I think I've had people like not believe me when I tell them like I only ever had to use take pain medicine. I only ever did it before physical therapy, because it just helps sort of you to like relax and helps the therapist kind of be able to push you more. And sometimes I would take them before going to sleep at night, because you do wake up stiff and sore some days, and so it helps to take some medicine before bed. But other than that, I only ever took medicine for physical therapy. It's not like I never took it every day and like when it was prescribed, which was probably, I think it's like every 4 hours. I never did that. I only ever had to take it like before physical therapy.
Yeah, and I would, and that's probably the majority of cases. Now, the patients who required more, it's not good or bad. It's just different. Everyone's different. But I think a lot of families are concerned that my child is going to take severe and high-level pain medicines for months and months, and they're going to become addicted, or they're going to have tolerance and all those things, and that's not true. I mean, sometimes if you're on a pretty significant dose of medicine, then I think at most you might have to wean certain medicines instead of abruptly stopping them. But even that's an extremely unusual situation. The vast majority of patients cope in different ways with both medicine and with positioning, with heat and ice, with all kind of things that become kind of more of a holistic approach. But it's definitely, there is definitely pain management because, that's needed to get through this process because it is a big surgery and it's a lot of recovery. So the next question is, my child is 2 and I know limb lengthening is something that will probably be in our future. When should we begin consulting? And whenever I have patients with various diagnoses, when's the earliest time? I said, whenever you want to. Whether it's coming to visit an institution that specializes in the care that you need, or even contacting institutions, surgeons, or surgical teams. There's lots of information available via Facebook and blogs, and even my practice, we have a chat. We chat every Thursday night with different subjects, and achondroplasia, bone dysplasia is one subject that's usually represented every month. And so I think it's just getting knowledge, meeting patients, as Chandler said, meeting individuals who chose to lengthen and maybe not to lengthen, just to get all the information. Families, especially, I learned the most about the most new innovative medical treatments because the families are out there looking. And so I think it's whenever you're ready to just begin the journey of knowledge, and you don't have to fear that someone's going to force you or pressure you into having any kind of surgery, because that's a very personal decision. Number 11, is it possible to gain 12 inches in one surgery? It's not. And so that's unfortunately not able to be done safely. I have done some extreme lengthenings. I have colleagues who've done extreme lengthenings, meaning that's probably the most that you can gain truly in one surgery is right about 6 inches, maybe 7. I have seen some examples in conferences and such of more extensive lengthening with severe complications. But in my practice, and at least in the practices I know very well here in the United States, and even some of the major centers abroad, that's not possible. So I would, expectations 6 inches is maximum at a adult aged size patient. 4 inches for younger patients for one lengthening. What is the youngest age you have performed limb lengthening on for someone with achondroplasia? What is the oldest? What age would you say is too soon to start? And is there a cutoff? Those are great questions. So the youngest, probably age 7. I think a 7-year-old snuck in there. Usually I do age 8. And I think that's just from the very first question, from a maturity standpoint, to undergo not just a surgery, but once again, as Chandler said, the therapy and it's and the journey that it takes to be very successful. The oldest patient I have performed limb lengthening on is probably in their early 30s. And I did humeral lengthenings, and a couple of patients who were in their late 20s, early 30s, probably 1 or 2 limb lengthenings in the same age group. the hard part about the age cutoff, there's not really an age cutoff. You can lengthen legs into the geriatric ages if needed. I have a partner who lengthens more time to take 6 months off when you're 14 or when you're 34. At least in my life, excuse me, so there's not really a cutoff age. I think it's more of a where does it best fit in life? Is it amendable with your life? If you're 30 and married and have 2 children, it's going to be extremely hard to undergo 4-segment lengthening. Chandler can tell you probably in extreme detail on how much time this takes and how much effort it takes. And it's a full-time job. Would you say, Chandler?
It is. My total, like, I always tell everybody, like, my total lengthening experience from I would say I consider the day of surgery to, like, not the day that I got my frames removed, but I know in some cases there's about 4 weeks of no weight bearing sometimes after a lengthening procedure. And so I count when you can start full weight bearing after you've gotten the frames off. I count that as like the last day. And so that's like that took me about, I think, 7 months. But overall, I think it's a total of 1 year to sort of get that full experience that, you were expecting. Like, I think it takes a full year to get the expectations that you were wanting. And so it does take a long time, but you're not stuck in those frames or in a wheelchair for a year. It's just that overall, it's, I think, a year.
Yeah, I think the overall kind of life change or, your routine change. And that's where I think the age is. I think from a medical point of view, either too young of an age from a psychosocial developmental point of view, and even, again, the theoretical, are you putting too much pressure on very young growth plates that can take away some of the natural growth? And that's why I kind of limit around age 8 as the youngest for both those things. And the oldest, it's really dependent on health, overall health, comorbidities, and also just the doability in that patient's life, family support, and so on and so forth. So that kind of leads into question number 13 is, what is the best age to start limb lengthening? How long is the hospital stay? How much time is involved with each lengthening? So we can hit on a couple of those. The best age, really, I think it depends on the family and the patient. You can start as young as age 8. You can start as young as I've started some at 25. Now, those patients who are older who usually had 1 limb lengthening, like 1 humeral lengthening or 1 lower leg, if you're going to go through the full protocol and your anticipation is an overall gain of 10 to 12 inches in overall leg length and 4 inches in humeral length, then starting sometime between the age of 8 to 12. But you can start as even in the mid-teens, and Chandler can give you her experience.
Yes.
Yeah, go ahead, Chandler.
Oh, I started at age 17, which I was a junior in high school, and I remember thinking, in my high school that I went to, junior year was kind of like the year everybody was like looking the most forward to. Like, everybody looks forward to senior year, but for some reason at my high school, junior year was like the year that everybody looked most forward to for some reason. And so I remember being like sad that I was going to sort of miss out on that. But, the experience that I had, I was, with lengthening, I was thinking like, I had the expectations like, I'm just going to be doing this for like 6 months, but that's not the case. I mean, I was able to, a lot of people I think, their child will be confined and not doing anything, and that's so not the case. I know some of the former patients that have, they went to school in their wheelchair, like they went out to the movies and stuff. And I think it's important that parents understand, like, your child's still going to be living their everyday life. It's just kind of like you're sort of stuck in a wheelchair for a few months, but it's not that I'm trying to see how I can phrase this. It's not that it's a long, time of just nothing and you're waiting for, your legs to be longer or whatever. Like, you can still do your day-to-day life that you did before. You're just stuck in a wheelchair.
Yeah, it's definitely a modification of your routine, but you're right. It's amazing. And Chandler is a great example of how young people and teenagers adapt to their situation and move on with life. But you do have to be prepared for that modification in your routine and an impingement on your independence and things of that nature. I think how long is a hospital stay? Usually the inpatient hospital stay is 3 to 5 days. It's the post-hospital stay that is required, especially in lower limb four-segment lengthening. The humeral lengthening is a little bit easier, and you can go back and forth to home, and those are a little bit different. But the leg lengthening, it's depending on the goal, it's 2 to 4 months of every 2-week visits, daily physical therapy, and usually, unless it's an extremely unusual situation, you're kind of here on campus, meaning that you're in housing here. Some patients go home on the weekends and come back, but it's it's the safest way to go. How much time is involved with each thing? A lot. So, that's just a lot of, you have to really set aside, it's going to be a 6-month endeavor of visits and changes, and then another 6 months of even improving with physical therapy and getting back to yourself. Number 14, is there any procedure to help my son's arms straighten more than they currently do? He has achondroplasia. And so the humerus is another bone affected, because achondroplasia and hypochondroplasia is what's called a rhizomelic dysplasia, meaning that if you look at your bone segments, the ones closest to your body, that's rhizo. Meso is the limb segments that are in between, which is your forearm and your lower legs, and then acro, which is your hands and your feet. So the rhizomelic dysplasia means the effects on the humerus and the femurs are more so than the rest of the segments. And the humerus, it can have different configurations, meaning at the end of the bone can be bent, where you have lots of elbow flexion, touching your shoulder, touching your ear, touching your face, but you don't have as much extension. You might be locked out, maybe lacking 30 degrees from full extension. So you can straighten the bone. And sometimes you have more kind of an angled appearance to the arm. So the bones can be straightened. If the bone is simply being lengthened in achondroplasia, then the bone cut's done closer to the shoulder, and you can gain about 10 centimeters of length in one bone. That takes a long time, but it can be done. If it's a straightening procedure, then the bone cut is closer to the elbow. You can lengthen through that also, but you're only limited about probably an inch, probably 2 to 3 centimeters, because of the way the musculature is arranged in your arm. You undergo significant tightening with small amounts of lengthening. But the elbow can certainly be straightened, and you can even add a little bit of length. I've had some patients who undergo a lengthening procedure and then in a sequential operation several years later do a straightening procedure, depending on the goals. Number 15, I am from the UK and I have achondroplasia. I've been receiving limb lengthening operations since 2011. My legs, and shall have my arms lengthened in the future. I've received over 10 inches of height and had my tibia bone straightened, and I'm very pleased. I still have, I shall be having another frame on my right leg to correct some problems. I was wondering, what is the arm lengthening procedure like? Is in terms of what can you do with frames and the physiotherapy? So the arm lengthening is significantly less involved in the lower legs, but still involved. But especially in this particular patient situation, after having undergone lower limb lengthening, the arm lengthening probably seems very easy. Is that true, Chandler?
It's such a piece of cake. It honestly is. You're just kind of walking around with these metal things on your arms. So,
So,
like,
you know, so
there's no, that's how I always saw it. I know there's really no resistance or something. Like, I think the only restrictions was the word I was looking for. I think the only restriction that I had was like not lifting anything over 3 pounds or a pound or something, and don't pull or push open heavy doors and stuff like that. Which that was fine.
yeah, that's what, and I think it's either goes to show you that the lower limb lengthening really it's a challenge, because, but in comparison, the arms are much simpler.
It's such like I always forget that I even did them because it was just so easy. Like
Exactly. The one I still use external fixation pretty much exclusively for the arms because we do not have a internal humeral rod that will fit most patients with achondroplasia, either in length or width, that can achieve 10 centimeters with one lengthening. Being a developer of the precise nail, I have inroads with the company and still with the company. They're now Nuvasive. They've been bought, Lips was bought out. And the engineers, myself and John, we still have our projects. And so that's one of my priority projects is to create a nail that's specifically designed for bone dysplasia, all 3 segments, femur, tibia, humerus. And so that's still undergoing. But even with the external fixation, it's a much less invasive, less intrusive into your daily life. Still requires some physiotherapy, probably 2 days a week is usually the average. The visits, instead of every 2 weeks, sometimes they're every 4 weeks. And a lot of times the visits, if the range of motion of the shoulder and elbow are doing fine and there's no nerve issues, then you're really just looking at x-rays intermittently to make sure that the bone is healing well. So the things in the day-to-day life that this patient was asking, like writing and getting yourself ready, you can do all those things. Now, there's going to be some limitations of range of motion. Chandler, was it hard to kind of like do your hair or get dressed or anything with the frames on?
not really. I'm trying to it's so hard for me to even remember. But I'm trying to think. I don't think there was any restrictions with, having the fixators on. Getting shirts on, definitely, just because of the sleeves, and you don't want to get holes and stuff in them. But other than that, I lived my life normally. It's just I had the frames on my arms. And I know another benefit definitely is for those who drive, and you're able to sit farther away from the steering wheel with your arms lengthened, and that's obviously I would say probably one of the number one things.
Yeah, I think that's a huge benefit from a community safety is that you're not sitting on the steering wheel because of all the airbags and problems. Great. So I think we'll reach number 16. Is when can we expect any medical treatment for achondroplasia? If my child has passed the age of 18, will the treatment be too late? So there are some medical treatments out there. I think there's a study or a trial going on, and I think it's in Sweden. I'm not sure. The endocrinologist, it kind of falls into the endocrinology world and genetics world, where is there possible, when you look at certain bone dysplasias and when there's a single mutation in the genetic code that creates a difference in an enzyme or a receptor, fibroblast growth factor, receptor 1, with all the advances in the genome project and things, those are the conditions. Cystic fibrosis is a single, mutation in a DNA strand. Those kind of things have possible chances of benefit. I don't know of any yet. I know there are some medical treatments that are being trialed, but you have to be growing. So achondroplasia, this specific bone dysplasia affects a specific receptor that creates a growth difference in a specific layer of the growth cartilage. So your growth plate has 7 layers. The zone of hypertrophy, where the cartilage cells are getting bigger, and collimated is where the effect of achondroplasia comes in. If there's a medicine that's going to reverse that, then that growth plate has to be growing, and you have to probably take this medicine, during your growing years. So I think it's very much in its infancy, but there is, lots of excitement, and I think there's so much innovation. I mean, if you think of our internal lengthening nails, 4 years ago we didn't even have them; they were still on a engineering desktop. We started that project in 2009, and now I do as many internal lengthenings on all conditions than I do external lengthenings. And so, especially for those patients who are already in their teenage years, then I think limb lengthening is still, if that's important to you, I think what we've been talking about is more pertinent. For the families with infants, 1 and 2 years old, who knows? So I would very much keep abreast with, the endocrinologists and the geneticists and the genome projects, looking at correcting some of those kind of issues. So I think
There was one question that a mother submitted. I posted it on the side if you can read it, but it's how often is it necessary for your trochanter surgery need to be done with 𝘾𝙊𝙉𝙑𝙑 who have limb lengthening? I think she was referring to all of mine.
Yeah. So it's interesting. So trochanteric issues, along with limb lengthening, I do lots of complex hip surgery for all kind of conditions. But so when you have a condition that's called 𝘾𝙊𝙉𝙑𝙑, and that just means the neck of the femur itself is very short, the ball of the femoral joint sitting into the cup of your pelvis has a certain relationship to the little bone just to the outside of that, and that's called the greater trochanter. That's where the muscles attach. If you have a short neck and the muscle that helps you walk without a limp is working just fine, then you don't need anything. And that's probably the vast majority of patients that I have dealt with achondroplasia. On the opposite side, patients who have 𝘾𝙊𝙉𝙑 from other growth disturbances, something called 𝘾𝙊𝙆 disease or infections, they require what's called a trochanteric transfer quite often. And so the patients who do have the bone dysplasias in a persistent swaying type gait, and we call that a Trendelenburg gait, a trochanteric transfer or a femoral neck lengthening with a trochanteric transfer can be very beneficial. So how necessary, it's really depending on the patients. How often, in my experience, I would say uncommon, but not unheard of.
I think that's it.
Is that it? Okay.
Great. I think you made it through the list. We have a couple callers on the line. If I'm going to unmute you guys, and if anybody
they already submitted all the questions.
if anybody has a question they'd they would like to ask live, please go ahead.
I might get like at the same time. I'll be like,
Or before you could type your question into the side.
like, give me 10 extra shots.
Okay, it doesn't sound like we have any other questions. So thank you so much for the callers that joined us today. Thank you, Dr. Standard. Thank you, Chandler, for being with us and for generously giving of your time. We really appreciate you doing this. Lots of great questions, lots of great answers that I think will be helpful for a lot of people.
Great, no problem. Be happy to come back again. Thank you for having me.
Thank
you. And if anybody listening to the recording has any questions in the future, feel free to type them in. Just go to growing-stronger.org to the LP Doc Talk page, and there's a form there where you can submit your questions, and just note that your question is for Dr. Standard, and we can get that to him. Or if you have a question for Chandler,
Yes.
same there as well. So again, our website is growing-stronger.org. Thanks everybody for listening, and thank you, Dr. Standard and Chandler, very much.
Thank you.
All right. Thank you. Take care.
You too. Bye-bye.
Bye-bye.